Hello, everybody. I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a very special open mic, Rethinking the Complexity of Wound Management. Tonight, we have a guest moderator, Korboi Evans, and I will introduce him right now. Dr. Evans, could you take the stage?
Good evening. It's an honor and privilege to be here with all of you. Thank you for taking your time to hear about the rethinking the complexity of wound management. I am Dr. Korboi Evans. I'm an orthopedic surgeon in the Washington, D.C. metro area, and I specialize in arthroplasty joint replacement. Prior to my current practice in D.C., I was an active duty military surgeon at Walter Reed during the height of the overseas campaign in both Iraq and Afghanistan, and it was an honor and a privilege to care for our wounded warriors. During my time in the military, we cared for high volume of complex injuries, blasts, wounds, soft tissues, and we utilized negative pressure wound therapy extensively throughout the management of our wounded warriors. The devices were applied in the battlefield and were deployed throughout the different echelons of care, from buddy aid to the combat support hospital and theater to regional centers in Germany and then stateside at Walter Reed. And I'm happy to share my experience with you guys this evening. You want to have my other panelists introduce themselves this evening?
Good evening, everyone. Meftah. I'm an orthopedic surgeon, joint replacement at NYU. I had the pleasure of working with Dr. Kirschenbaum for a while, and we've been doing some form of uh, type of a wound care at NYU for a while, and when we got the NP seal, this piqued my interest, and hopefully we'll have a great discussion about the utility and benefits of it for everybody. Looking forward to it.
Hello, everybody. My name is Jack Sizemore. I'm a physician assistant at Greenville, South Carolina. Been a PA for almost 17 years now. Started for about 3 years working in general orthopedics. I've been doing total hip and knee arthroplasties for the past 13 to 14 years. Have always been chasing down a great way for just a universal joint dressing that everybody could use and be happy with and would suffice wound care management. So happy to share our experiences with you guys tonight and appreciate you guys having us tonight.
So this is a very much an open conversation. Please feel free to ask questions as we proceed. Um, so wound healing remains one of the most important determinants of success in orthopedics. Regardless of how well a fracture is fixed or a joint is replaced, complications involving a surgical incision can significantly impact the healthcare costs as well as patient outcomes. One of the newer technologies that we deployed is the NP Seal, and negative pressure wound therapy in general has emerged as an important tool in orthopedics surgeons' toolbox for the management of acute and complex wounds. Today, we'll discuss the application, its use, and how we can better serve our patients. I use negative pressure wound therapy specifically for all of my elective as well as revision hip and knee replacements. And oftentimes I get asked a question, why negative pressure wound therapy? My answer is always the same, and it's quite simple, because wounds heal when they are dry. You have less risk of adverse outcomes such as infection, dehiscence, and return to the operating room. And to my esteemed panel, what has been your evolution in terms of the management of incisions and wounds over time, specifically as it relates to your patients?
I would just chime in when I first started, and so it's been 13, 14 years ago, doing total hip arthroplasty and total hips and total knees. We would put zero form, gauze, ABDs, wrap it with an ace bandage on a knee. I mean, to now, like, patients are basically spoiled to have one single dressing going over top of a wound where, and a lot of people are no longer using staples, they're using something a lot more refined in that regard too. So just the ease for patients, the management for patients has been much less. The less you're having to mess with the wound, the less you're getting any complications, so the infection, all the other complications like you mentioned, dehiscence, et cetera, has gone down tremendously in our practice.
Yeah, I was gonna echo what Jake said. We've come along in terms of managing wounds. Back in the day, everybody was staples and we would slap a dressing on top of it. Um, a lot of silver dressing that had allergies and reactions. Um, I can tell you almost all cases are primary and even some revisions we're using monochrome with some form of adhesive on top. But the benefits of negative wound pressures are fairly established. I don't think there's a debate in terms of does it work. I mean, it does. The benefits of it is quite well known in terms of prevention of bacteria, as you mentioned, Korbei, keeping the wound dry, and they're permeable. They're very convenient for the patient. I guess the question is, should we use it for everybody? Is there a case that benefits more? And also, what is the benefit of NPCL as compared to the other commercial available negative wound pressure dressing? I don't think the debate is should we use it. I think it's fairly established. I don't know what you guys think.
So when we first started using negative pressure wound therapy in the military, as I said, we had these massive soft tissue wounds, and everybody had basically wet to dry dressings, and it became cumbersome. And we eventually evolved to using wound vacs and then eventually incisional vacs, and we just found that the patient experience was much better, less painful. We had less reoperations, less infections, and as I said, we deployed it extensively throughout the care of our patients. And I transitioned to civilian practice, and now, as I said, I use it for all my revisions as well as elective cases. And I think the most important thing when it comes to incisional wound therapy as well as procedures is patient selection. So this device is not recommended for everyone, so you have to be kind of specific with the patients that you deploy it on. And can you guys speak as to how you determine which patients get your incisional wound therapy? As you mentioned, not every patient in your practice gets it. Just give us your thought process as how you figure out which patients get the NP seal versus which patients get Aquacel or another dry dressing.
So we typically will go with higher risk patients. Patients maybe be over BMI of 40. They have more soft tissue mass over top of their wound. Certainly, they're at higher risk for drainage and wound complications. So NP seals definitely an appropriate, great measure for us for application. And it surely is better for, as you kind of alluded to earlier, wound vacs that make noise in the middle of the night. Patients are already, they're not going to sleep well because they're having pain and having inconvenience with having recent surgery, and then putting on a wound vac that's going to keep them up at night and have to carry around a canister. That's all been tremendous inconvenience for the patient. So applying a NP seal where it basically it does the job for you. You don't have to worry about wound canisters beeping in the middle of the night, et cetera. That's been a major difference for us. But in essence, so for our practice in Greenville, South Carolina, we're basically doing patients of higher risk at this moment. Certainly people that you could use it in a variety of other patients, but higher risk, the people that may be on more potent blood thinners, things like that we know we need to take a little extra caution with.
Any thoughts?
I use it on everybody. To me, the high risk that you mentioned that have high, I'm worried about drainage. Then I use an incisional vac that has a canister. Instead of trying to figure out if NPCL is appropriate or not. I mean, why are we discriminating, right? If you're worried about the wound breakdown, I think every patient deserves to benefit from it. The decision comes in that if somebody's on Plavix, Lovenox, and or doing surgery, you see there's a lot of bleeding, and you're worried about drainage post-op, then a canister might be a better approach because then NPCL is going to get saturated within 24 or 48 hours. But other than that, I mean, I don't see any downside unless you tell me the cost. But other than that, I don't think there's any downsides to it.
Can you guys speak to how easy was it to adopt the negative pressure wound therapy into your practice, specifically patient compliance, patient education, as well as to the education of other allied health professionals who may encounter the device throughout the patient's care?
Yeah, so we've used I mean we'll use Pravina if we do like a revision, something that is way more complicated. But for the most part, the application for the MP seal for us specifically obviously goes on very easily. Um, for the I guess for the vast majority of our people, really haven't had to change out a wound or a MP seal, but our home nursing staff has been equipped with MP seals. So if they have to swap one out because it does become too saturated, they can do that for the patient when and if needed. So that's another or a better application for the MP seal because of the ease of swapping it out for the patient if needed.
We have a question from the audience. Arjun Patel, you want to ask your question?
Yes. Hi. I was just curious, do you guys use the negative pressure wound dressing at the surgery center too? Just trying to evaluate the cost benefits analysis to using such a dressing on an outpatient basis.
So that's a very great question. And I utilize NPCL for all my cases, revision as well as primary at the surgery center as well as the hospital. And we did a value analysis at the surgery center and we realized that by eliminating certain dressings, like we don't use Dermabond anymore, we don't use monocryl, that we were breaking even or even coming above with utilizing an NPCL. And my sell to the surgery center staff was if it can save us returning one patient back to the operating room because of not having wound dehiscence or drainage, it was definitely worth it. So we utilize it on all our patients at the surgery center.
Yeah, Bob Everly, you had a quick comment, and then we'll go back to the surgery.
Yeah, there's three key papers if you want to really dive into NPWT. It's the first one's by Cooper, second one Gronin, and the third one Nerera. They're all meta-analyses. They basically look at 50,000 patients across all major surgical disciplines. They come to the conclusion, one, that all surgical wounds are the same through the first bit of the first layers. So there's no reason why you shouldn't use it. Negative pressure, any negative pressure, they also say that you have to keep it between negative 75 and negative 125 negative pressure. That's a bit of a misnomer. Pressure isn't negative. It's the vacuum is pulling. And then the last thing is the Nerera paper is a calculation based on Medicare and NHS systems. The cost savings are ridiculous, and in the long term. And basically, if you're going to caution in using it, make sure that you put it at your most high risk patients because there's the ones that'll benefit the greatest, and they've shown that in the results in that paper. And Dr. Kirschenbaum, if you like, I'll forward you the three papers and you can distribute them if you'd like.
That'd be great.
Does anyone have any question that negative pressure doesn't work? I don't think that's the issue. The question is the cost. Medicare saves money, but how is that passed on in the private practice world?
There is a CPT code for it.
They don't pay it.
They don't pay it. I mean, so not for bundles or Medicare, but some commercials you might be able to get RVUs or some. I think, do we have anyone from Stryker on? It might be about, if you get reimbursed, it might be $150. But there's a code 97607.
What's the cost of it? What's the cost? I love negative pressure. I was one of the first one there to use it 25 years ago. But no one covers it, and it becomes a dead loss to the bottom line in private practice.
Yeah. Well, so that's, sorry, go ahead.
Hi, someone from Stryker, Sophia here. I do want to say that Stryker does have a third-party system, JDL Access, that has been really great in being able to give some insight on reimbursements. I know a lot of my fellow surgeons have been using them, and they can be clear of what you can get from different insurances and Medicare and Medicaid and so on. So we can distribute that contact information.
Does Medicare cover it in a surgery center?
I don't think so.
I don't think so. I've submitted the 97607 code for commercials and have gotten reimbursed. The surgery center as well as the physician payment is definitely not within the bundle fee, but there are certain commercials that will reimburse for that 97607 code for the negative pressure wound therapy if appropriately dictated in the operative note, because I think that's key. They all request the op note to see how it's utilized and deployed. But with appropriate documentation, some commercials will reimburse for it.
Yeah, I would love to use that. Unfortunately, 90% of my patients are Medicare for the total joint world, and that's just how much. What's the Stryker system cost? Anyone know?
Yeah, let's get that out.
Yeah, I'm happy to help weigh in here if it's okay if I speak up. My name is Brady Brink. I work with Stryker. Have been with Stryker about 16 years. So we acquired Guard Medical just over a year ago. So this reimbursement world, this is newer to just our product portfolio that carries this. So we're learning a ton. Sophia is one of our reps that chimed in. We're partnering with third parties to help figure this out. The code that Dr. Evans and some others mentioned are the one we have, that's being used right now. So we can always follow up, separately and get answers there too. On average, the average cost of an NP seal is roughly $175 to $200, depending on different sizes and a couple of other different pricing factors in place. So we've been really excited to come to market with a more cost-efficient product offering, and we're navigating that reimbursement world and figuring out a lot there as well.
Yeah, I can build on that. Going to VAC for any institution, if they're using other product like Pico, this is a no-brainer because it's actually 50% cheaper. Not to mention patients love it, right? You don't have the canister, you don't have the tube. I don't get calls, during the day or at night. It's blinking. What do I do? It's just, it's so much easier for everybody. And also, if for example the pump is not working, it's still a good dressing. Could stay on for 2-3 weeks. You don't have to change it. So the question is that if assuming you're not getting paid, then it becomes one of those green checks that Ira is talking about, right? It's one of those that's worth paying for because at the end it saves one patient from going back to the OR, wound breakdown, or at the end of the day, I think it provides value.
I'll give one specific retort to that. So I do direct anterior exclusively from my hips, and we all know who the surgeons who do DAs. The patient has a pannus and they have that incision that lies right under the pannus, and those wounds don't get aerated. Sometimes that can lead to superficial and deep wound complications, and oftentimes those patients may have to return back to the OR for debridement. And I specifically use NP seal, not just for those patients, but all patients. And I haven't had a patient who's had an issue in that specific region. So as we've all mentioned, if it saves one patient going back to the operating room, it is definitely worth it.
Yeah. Tom, what are your thoughts?
What are my thoughts?
Yeah, $200.
Well, I heard a political dodge of what it costs.
No, $200. $200, they said.
But whether it's reimbursed, excuse me.
Oh, sorry. Let's assume it's not reimbursed. Let's assume it's not.
It gets tough. I mean, this is where the decreasing numbers start biting into good clinical decision making.
What if it's $100, Bob? Because think of it as our bundles are close to, I mean, ASC is cheaper, but hospitals are 25 to 30K, and vast majority of it goes to post-op physical therapy. And in terms of saving costs, we've eliminated almost all the total hips going to home physical therapy. I would say 99% go home and same day. And total knees, we've reduced the home therapy or outpatient therapy by I would say 60-70%. So if this is 100 or 100, and I'm not working for Stryker, I'm just advocating for patients. If this is 100 or $150, why not, right? Where is it coming from? The hospital makes more money?
It comes down to whether are you hospital employed or your private practice?
No, I'm a physician with NYU.
Are you in private practice or hospital employed?
But and NYU Hospital, Langone, it's one of the
I know,
big.
but are you hospital employed or are you private practice?
Employed.
Employed. There's no
That,
private practice.
Employed.
that is the difference. It doesn't make any difference to your reimbursement. It does, and it comes down to and I hate to be this guy,
No, it's good. It's good.
but if the cure for cancer is invented, but no one can afford it, then no one gets it. And as they cut reimbursements, I'm privately employed in a hospital. I would love to use negative pressure. I have used it many times. In the surgery center, tend not to, because it cuts significantly into the margin, and that 1 out of 50 that really benefits from it, you have to use it 50 times. It's tough to make economic sense.
I'm gonna intervene for a second. I'm no stranger to economics and healthcare. I find that if you're an ASC, and you're making 9,500 for the case, or or 11,000 or 12, depending upon your contract, of course, you kind of always have to make a decision about what the long game is. And I challenge, if let's say it's $200, and let's say you get $10,000 for the implant, and 200 over 1,000 cases is $200,000. I get that, Tom. That's real money. I challenge people, when you find an advance like this, to find cost savings somewhere else in your institution, because nobody is that lean. And if it's that important, you can find you could find 3% cost savings somewhere else. I'm not saying whether it's Exparel. I'm not saying I just said it was Exparel, so I can't say I'm not saying it wasn't Exparel. But I'm just saying somewhere.
No, I get that. I mean, I will argue that Exparel is the anti-argument, because Exparel, because the Pain Act is excluded, and it's actually outside.
Well, I don't mean Exparel, but I'm saying, so I'm saying another thing. Somewhere in your fixed cost structure and somewhere else. And sometimes I also often ask myself the question, because I am the value analysis committee at my hospital. I am employed, but I am responsible for cost across the board. That's my job. So the reality is when we bring something in, we also have to ask. We're at risk on certain payers. So if we do get a infection on our at-risk insurance, it's a problem. But the big question I often ask is, if this product, NPCL, came out first, before zero form, even before
Thank you.
Something else, would you ever replace it with something inferior? If it is superior, and it's a superior innovation, and it came out first, would you ever go away from it and choose something that increases your infection rate? And that I think is an important question. Kevin?
Yeah, so you took the nail on the head. I'd like to take economics out for a moment, if you don't mind, for everyone. I'd like to hear BMI 28, no PANIS, no diabetes, things of that nature. Sorry. Why am I changing? Years of not having a problem. Is it the preoperative patient that we're choosing to operate on? Dr. Evans was very wise. When you have a complex patient and not maximize their health care, maybe we need these wound dressings. It's exactly what I'm saying. But if you maximize their health care or their health, and I'm lucky I'm not in the Midwest where they're bigger, do I need to do this? And that's what I'd like to hear from the panel, which is a spin-off of exactly your question.
Yeah, Richard Bush had a question on this too. Rich, love to have you.
Yeah, can you hear me?
Yeah, very well. Thanks, Rich.
Yeah, it's the same old problem and things, and it does come to dollars and cents. The two best things on the market in the study previously, for the wound is negative pressure and silver dressing, Silver-Lon, things like that. Those are the two top ones. Okay. So if you can do that cost effectively, fine. Kevin's right. If you got a healthy patient, why do you have to do all this stuff? Maybe on higher risk patients, BMI, diabetics and things, it makes more sense. Medicare in our area only pays 12 to 13,000 for the care of that knee. All right. That includes everything in the hospital and everything afterwards. If we had $200 or $300 for all these things, and you want to add the new pain controls and all these other things, all of a sudden it eats out the profit for the hospitals. All right. And they're getting killed right now. So it's great for us to come up with these new things, right? But at the same time, cost effectiveness, especially in ASCs, can be a problem.
It's all very
So is getting that 1 or 2 or 5 or a half dozen INDs. What's the cost of an IND? Or what's the cost of taking a patient back to debride a wound, whether it's superficial or deep? You know, those costs really eat into whatever profit you may have in the first 90 days, because that's where especially the wound issues are going to occur.
Okay. Hey, let me answer Bob here. Okay. You can't treat the one case scenario, Bob. Okay.
Well, it's not
you
one
can't do
case.
everything across the board. Those things happen. Okay. And you can't sit there and always do everything up front to try to avoid a potential problem, because they're going to be there. All right. You got to understand, we are under so many guidelines now and so much push to do things cheaper and cheaper and cheaper. And if you didn't just see CMS wants to reduce us another 20%, this is not doable anymore. All right. So you have to make choices in patient care anymore.
But I think what Dr. Plancher said a little earlier was select the patient. Look at the Nerera paper I put on there. If the patient's at high risk, where there are multiple comorbidities, diabetes, smoking.
Okay, that's what I said, Bob.
Put it on
You didn't
there.
listen to what I said. That's exactly what I said.
I think we're all in agreement that patient selection is key.
Right, exactly.
So you have to evaluate your practice. Every surgeon has a different cost considerations at the hospital, at the ASC. If it's valuable for your patient and it's going to make a difference, then absolutely deploy the device. But patient selection is key. I think it's one of the first things that we highlighted. In our practice, we use it for everybody because we found that it helps us at our bottom line, but it may be different from patient, center to center, facility to facility.
Well, I think the error there is, I agree with you. I think what you do, you should do it for everyone, because you put yourself up, if you've chosen to do a different standard of care for one patient versus the other, and they have a negative outcome, you're at risk. So what I do at the hospital, I do at the surgery center. Implants, dressings, you name it. Number two is relative. I'm gonna put my glasses down. Bob, it doesn't cost me anything if a patient has an infection or has to have washout. I actually get paid. It's a sick situation. It costs the insurer money, but doesn't cost me anything. I don't like that. My patients are my friends, my number one priority, but you're confusing the situation. It costs the health system a lot by taking them back for an IND. If they reward the provider for the health system savings, everyone would be using negative pressure. I would use them 15 years ago, 20 years ago. That has to be covered in much like Exparel is now covered in the Pain Act. Some of these things have to be covered, or at least the bundle has to have enough room in it, or it doesn't happen.
Thoughts about that? Okay, sorry, go ahead, please.
I still go back to what I was saying, and I love the comments and what people are saying. It is, I'm going to say it to my colleagues. Was that joint necessary to be done? Did the patient not get maximized? Maybe you have to wait. You know, when they said, what about the one IND? It's a very valuable statement, but maybe the IND doesn't happen because the patient doesn't get the joint, because we're floating volume to the bottom of the sea. So maybe we have to take a look at ourselves and truly turn to patients and say, you're not ready yet. Your health isn't maximized. You're a risk and you can't get fixed yet. It's time to get healthier. And that's a strange thing because I'm a surgeon and I like to operate and I get it. But I get it when you have to change dressings and do these things to protect many things, whether it's legal, economic. But I would love us to be critical for the 28 BMI, 30 BMI. I would love, because I'm not smart enough, I would love the panel to describe for me what are the active ingredients that are now helping us to heal wounds, and did other people, cardiac, dermatological, use these things before us, besides negative pressure. It's been around for a long time and I couldn't agree more with people. But some of these newfangled dressings, I myself, I'll go on record, I used Aquacel. I was an idiot. The wound wasn't dried off. I got a 3rd-degree burn when I put on my Aquacel. I don't use it anymore on a very famous person. And it was my fault for not having a dry wound, and the silver pregnated thing caused a 3rd-degree burn on the patient. On a knee.
Well,
So
Kevin, I completely agree with your comments. I'm a nutritional optimization person preoperatively. I think we do that. That's something we have not done enough on. You know, the hemoglobin A1C, get the BMI down as much as you can. Preoperative protein loading, all those things are absolutely essential to elective outcome results. I appreciate you saying that because I agree with that. I'm a big fan of Andrew Wickline's, the Sultan of Swell. I'm a big believer in you do everything you can to control the swelling. There are those patients who bleed, though. I mean, I wish I could afford to put 100 dressings on for that one person who bled a bit more and drained a bit more. I can't in my situation. I just can't.
I think I'd like to chime in. I think so much depends on your community, who you are, and who you operate on. We just got accepted for publication soon to come out in JAOS that our community in the South Bronx has more than 3 times the comorbidities than any known published article in the history of arthroplasty. 3x. And in a lot of ways, we're not going to say goodbye to the community. We're going to optimize them. But some diseases don't get optimized as well as others. And even though that disease is optimized, they still have multiple comorbidities and are at risk. I would make an argument in a safety net hospital that I'm at, we should probably use a negative pressure dressing on a higher percentage of patients that we're currently using it on. In the patient selection world, maybe almost everybody, considering our comorbidity status and who we're operating on. If you're operating in Jupiter, Florida, which I've heard is a very wealthy area, and everybody is a BMI of 26 and well controlled everything, maybe not. But I think we're kidding ourselves if we think that we don't have we do have different populations and selection. I think as we start using these products more, we're going to hone down on who are the most ideal patients, who are the least ideal patients to get this technology, and the key is going to be parsing out the middle. And I think that's an important thing with an innovation like this, because we can't wait to get our hands on a simple dressing, because the people of South Bronx who we care for, I don't think they can handle the tube and the reservoir and drainage. A simple dressing like this is a home run.
Yep.
Yeah, I don't know what your thoughts on that.
So I have patients who've had NP seal on one side for their hip or their knee, and previously had another device, PFOS or Ravina, what have not, and their experience with NP seal was significantly better for the reasons that you mentioned. There's no tube, there's no alarm. The patient involvement is very minimal. They essentially have to check the device 3 times a day. So the ease of use is great for the patient experience. And for the other panelists, can you describe how you educate your patients when it comes to utilizing a device once they are discharged from the surgery center or the hospital setting?
Yeah, I just want to chime in real quick.
Yeah.
We've had people that we've used Aquacell, and then 6 months later we did a NP seal on the specific patient, and she was absolutely thrilled with her results. I mean, she raved about it, said it felt more secure, tighter. Just it was still flexible. Still, she had great range of motion 4 weeks post-op, all that stuff. But just the flexibility and her satisfaction directly compared to and recently compared to Aquacell was, I thought, was really important to hear. So that was great. Just great kudos to NP seal for us. But we typically advise people when they go home. Typically, they'll do the pinch pump 1 to 5 times about every 8 hours, or we tell them every time they eat a meal. So breakfast, lunch, dinner. Give it 1 to 5 pumps. Make sure that it's shriveling up like a raisin. Just easy tidbits for the patient for them to hear. And then those things, I mean, those are everybody can grasp, and the patient's usually pretty good about compliance with all that.
Yeah, same. I think application of it. Didn't we have a video to show?
Yeah, I
might
could
be-
bring that up.
That'd be
The
great.
application of it requires in training. I think it benefits the surgeons and the nurses, circulators in the OR to know the sizes and how it's applied, inflection in the knees, and then you get into extension to get rid of the pump, to use a pump to get rid of the air and seal it. But there's a very brief description of post-op care that we give to patients. It's fairly easy for the patient to care for it.
Yeah, the patients go home with a simple 3x5 card, try to manage the dressings, the simple pinch pump 3 times a day. So the patient compliance has been great with the device.
Can you see my screen?
Yes, but the video is not working. Are you?
Well, I'm going to get the video working now. Is the video working?
Yes.
It is.
All right.
This is the patient, lateral decubitus position. You can see the surgeon now applying the NP seal, adhering it to the dry skin, removing the adhesive. And then you will see him doing the pinch pump, essentially activating the vacuum suction feature of the NP seal. It comes in different lengths, so you can use it for total hips, total knees. I use it for my elective trauma and high-risk patients, as well as some of my sports cases.
That's really good. Yeah, why didn't we all think of this? Well,
Can I add a little bit on optimization? I think Kevin brought up a good point. I can tell you, at least in our experience at my institution, everybody's optimized, and I think part of the being proud of being one of the lowest complication institution in the US is because we optimize everything. The problem is not optimization. The problem is what happens after surgery. A lot of wound adhesions or complication could happen in patients that already have diabetes and immune problems and such, but it could happen in regular 25 BMI of commercial patient. You can't really. Infection does not discriminate, and those are the ones that you scratch your head and what did I do wrong, right? Or a diabetic patient that preoperatively the fructosamine or A1C is okay, but after they go home, all of a sudden the sugars go up because they're not waiting for you to watch over them to get optimized. It's hard to predict who are the good. I mean, we know some things correlate with infection. That's well known, but also there are healthy patients that get wound breakdowns. So that's why if in my thinking is that if this benefits my patients, then I will save money from cost of implants or unnecessary visiting services, or sending him to home physical therapy, or using some form of a dual mobility implant instead of a large femoral head. There's so many things that I can do cost saving. This to me makes a lot more sense in terms of patient care. But I understand that there are things that everybody has to think about in terms of cost benefit analysis.
Richard, you raise your hand?
Yeah, I don't know if you guys covered this. I got in late. We got a big push, at least in our area, to add collagens and all these things to help wound healing. All right, and all these wounds before you put wound dressings and things on. Can the panel comment on all these things to try to help wound healing? And does any of it make a difference?
We had a similar push in our area with the collagen dressings and so forth. We actually tried it for a period of time for our wounds, in addition to the negative pressure wound therapy and all the other optimizations. We actually stopped using the collagen dressings because we found that it was more hassle than it was helpful. And we just essentially utilized the negative pressure wound therapy devices, as well as maximizing and optimizing patient care prior to surgery.
Yeah, because the whole thing doesn't make sense. But man, we have all these guys putting this in right and left everywhere.
Absolutely.
And an increased cost. I don't understand it. The NPCL, we used it early. Bob Everly introduced me to it. It was great. But I got guys from Texas. I'm from Texas. The patients couldn't remember the pump damn thing. It drove me nuts. And so the comment is, once the patients are out of our hands, and I'll teach you guys, we already did a study on this, 80% of patients are non-compliant after surgery. So no matter what you do sometimes, we're going to screw it up. Human nature is they just do things that can screw a good result in a minute. And sometimes you have no control over that, guys.
Maybe there should be an NPCL app that 3 times a day reminds the patient to pump.
You should.
Yeah, I think I'll write that right now and send it over. And
maybe it zaps them.
Yeah.
Well, like Dr. Meftah said, even if the pump doesn't work, it's still a great dressing. I mean, people have been very satisfied because we've had people like that, the pump just doesn't work for whatever reason, and still been quite satisfied with their results with it.
And the dressing is a hydrophilic foam, so it collects a wound exudate, but it also has pores where it can evaporate. So sometimes it gets saturated, but the incision stays dry because the exudate evaporates through the pore. So sometimes patients do forget to activate the pump, but there's been no negative effects of that. So still a great dressing.
What is the volume the dressing can actually absorb?
So it's designed to be incisional only, but depending on the size of the length of the incision, you can hold quite a bit. I had a patient who at one point had some more drainage than I expected. It was over a snowy weekend. I was in the DC metro area, couldn't get him into the office. And I said, come and see me on Monday when the office was open. Essentially, most of that exudate had evaporated. So we're seeing that sometimes it can hold more than we expected just an incisional dressing to hold. I don't have the exact number, but I was quite surprised and pleased with how much it contained prior to saturating the dressing and leaking.
Because the ones I really like this for is those who are mechanical valves, et cetera. They're going to be anticoagulated aggressively post-operatively, and they can sometimes put out a fair amount if they've got a good range of motion and they're flexing to 100 degrees a week, which they should be. They can put out more than 10 or 15 cc's. That's where I really like a Provena or something with a canister, because they put out more than a dressing typically holds.
Yeah, so those patients may not be ideal for NPCL, but you're absolutely right. If you have a patient with a large amount of exudate, maybe another device may be beneficial for them.
Ira?
Yeah.
Could the panel comment on who closes their wounds, who
That's
applies the dressing? I'd love to know, are they running multiple rooms and they're experienced, and maybe that's why things are really good. I just don't know. I'd love to hear.
Let's go through it. Yeah. Mort, who closes your
I
wound?
can start. I have fellows and residents in each room. We do about eight cases a day, but we have a dedicated PA in each room that monitors the closing, and they apply the NPCL.
So I'm in private practice. I run 2 rooms with 2 sets of teams and a PA in each room. They do the closing. A lot of education goes into the closing just to make sure that the wound stays dry when and applying the device. So my PAs close and apply the device.
Jack?
So I'll close for us. We run 2 rooms, usually do 6 cases a day. Very particular about how I close, and so I usually run a monocryl, do a zip line, and then NP seal, depending on what location we're at. Part of why we use what we use, because at the surgery center we have availability of the NP seal, ironically, and then at the hospital we don't. But anyway, so I'll use the NP seal over the zip line for when I close. So, and I do all closures for our team.
Interesting.
That's a good question. Does anyone use anything under the NPCO like silk or bridge or anything else?
I use zip line. I think Dr. Evans does as well, right?
Yeah, so I use zip for my incision closure. It just saves time, and then I put the NP seal on top of that.
I'm gonna strike you guys. Is it possible to avoid anything underneath? Like not even any adhesives, any silk or any glue?
I guess you can if you're running like a monocryl or something like that. Is that how do you close your wounds?
We tend to use silk because we're using randomized clinical trial between different types of closures, but I was just wondering because that's another way of cost saving. Because if you don't have to use anything under it, technically you're saving some money.
I believe Dr. Asa Shaw over in New Jersey published in JOEI about a year ago on a series of cases, I think 30 cases, and used 3 different closure techniques, seeing which yielded the best. So I'll look that one up and throw it in the messages too, or a link to it.
Antonio Chang just came out recently with a report of the different wound closures and said the cuticular, the way those guys are doing it, was superior over suture, and staples was third.
Where was that paper?
I'll go look it up and send it to you so you can put it on the thing.
On one of those lesser publications.
Yeah, I heard there are lesser publications in orthopedics than Joey. Yeah.
I would love to see that, because I did subcuticular for a long time, and I took too many patients back for washouts because of prolonged drainage. I went back to good old fashioned staples. I would love to see that paper.
Yeah, I'll find it for you guys.
Maybe I'm doing something wrong.
Now we all do something wrong. Don't worry.
So the zip device from Stryker is excellent because it obviously.
I love the zip device.
Yeah, you can try zip, then you don't have to use technically don't have to do a sub-Q closure.
Yeah.
Can you use the NP seal with the bridge as well, or is it too bulky? Do you know that, Jack?
I don't know. I'm not familiar with the bridge, to be honest with you. That's a new one.
Yeah.
I think it's too bulky.
Yeah, I think it's maybe too bulky. Yeah.
Yeah.
It's very, 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 very interesting. This is the paper in JOEI that optimizing wounds using a non-powered negative pressure wound dressing, first 100 cases in outpatient setting. Sik Shah, Bob Everly. Was this with the NP seal? Yes, it was. When it was Guard Medical. So this got 2,507 views. So I just showing you can see this, right? Yeah. So this is kind of a nice paper looking at that. I'll stop to share. Yeah.
And like I said, I think there were 3 different closure techniques, and the third one was just nothing underneath of the NP seal, and that seemed to be the most useful and the easiest to apply, and I believe the least expensive.
Interesting. So welcome to the fastest hour in orthopedics. All right. As I like to say, some people could have gotten a joint done even during this time period.
Yeah, for $1,200.
For $1,200 for an hour. Yeah,
Yeah, for an hour.
But yes, no, for the whole team. Yeah.
Yeah.
And so let's go around. Let's start with our moderator for some final comments. And Korboi, thank you so much for moderating tonight. Some final comments from you and the rest of the panel.
Yeah, so I really simplified my practice by using the NPCL device and negative pressure wound therapy in general. It's something I believe in, given my military background. Got introduced to it and taking care of our wounded warriors, and it's since adopted it into my practice. And as I said before, why do I use it? Simply because it works. When incisions are dry, they heal, less risk of complications and infections and return to the operating room. So I encourage all of you to give it a try.
More?
I would just
Jack.
Oh yeah, sorry. I would just say we just with the success we've had. I hope you guys do give it a try if you can, if you have it available in your location. Just for the simplicity of the patients, the ease of the use, the benefits that it's provided for us. It's been great. I think everybody else has shared their success with it, and I hope you guys try the same.
Yeah, same. I would say that if you're thinking about problems with the wound and trying to optimize healing, then and you're thinking of some form of negative wound pressure, NPCL is the most patient friendly, user friendly. But at the same time, if you're worried about too much drainage, you might want to think about canisters, Provena and such.
One thing also just chime in. We had one patient just talking about canisters and all that. One application for NPCLs that we had a lady we had to wash out, BMI of over 45, had Provena on for probably 2 to 3 weeks, but then we helped transition because her drainage did subside to NPCL. And so that was like a night and day difference for her getting off the canister onto an NPCL. So I just if you have access to some, that application was great for the patient as we had to transition her off of we're able to transition off the Provena and then able to get her onto an NPCL for a couple of weeks until her drainage fully stopped.
All right. So I want to just make some closing comments. This was one of the most lively open mics we have for a long time. That's why they're called open mics. This will be soon on our YouTube channel and on View Medi, and it will also be available on our Spotify and Apple Podcasts. And I want to thank everybody who came tonight and thank Stryker, thank Dr. Evans, Dr. Meftah, Jack Sizemore. Just a pleasure to see everybody tonight. So thank you so much and good night.